Good evening, everyone. Thank you for coming. I'm Ginny Stimson, the chair of the Low Vision Hearing Challenge Committee. And we heard a while ago about a talk that Dr. Toner gave during COVID, and it was given as a Zoom presentation on the aging eye. And ever since she gave that presentation, now probably a year ago, we've been after her to come to give that presentation here because people who saw her said, this is something people at Horizon House would appreciate hearing. Well, we've had her scheduled twice when it had to be canceled because of flare-ups. And then she had a baby, and she's even brought a picture of the baby for us to see. So it's time now, the baby. I told her she could bring the baby tonight, but we didn't get the baby. But it's time now that she could come and be with us. And thank you so much for being willing to share this time. And I asked her if she's getting sleep yet, and she's not, but she's still here with us. We know what that's like, right? The questions will be held off to the end, and we have 3 people with microphones at the end. And I've told her how we're trying to use this microphone now so that as you turn your head, you can keep it with you and everyone can hear. So don't hesitate to say if you're having trouble hearing. Thank you very much.
Yeah. Hello, everybody. What a wonderful, wonderful home and community you have here. I hope you all feel as lucky as I feel to be here today. And you were promised baby pictures, so we'll start with baby pictures. I did not bring him with me. Yes. That is my Tony. He is 9 months old next week, so we are still not sleeping yet. But this is him last week at the pumpkin patch. So he had a great time with our dog, and our dog's name is Breakfast. She's a corgi. So we are busy at my house right now. And I apologize for taking some time to get here. Yeah, it was a bit of a scheduling snafu, and she did so much work to get me here today. So please thank her on your way out. So you might be wondering, some things about me. Who am I to be speaking to you today? Well, I am a Washington native-ish. I was born out of state, but I grew up in Bellingham, Washington. And I married my high school sweetheart. One of my very common questions from my patients now that I am in Capitol Hill is that people ask me if I'm related to the Toners that lived in Ballard. Many of you may know them, may not. Totally fine. We don't know them at all. So please don't ask me questions about them. I cannot answer them. But Toner is my husband's name anyways, so I wouldn't know regardless. But I did my undergrad at Western Washington University, and I stayed on for a master's because I didn't know what I was doing with my life. And then I changed and decided I was too lonely doing research in chemistry and went to UC Berkeley for optometry school. And then I moved back up and did my residency at Kaiser and stayed on there, and now I work in the Capitol Hill campus just up the hill, and it is a good fit for me. And my professional interests that kind of have landed me here today is that I really enjoy doing low vision, and I'm actually currently trying to start a more expanded low vision program through Kaiser Permanente, and I am doing all sorts of work behind the scenes to convince the powers that be that it is a good idea for us to do that. So wish me luck in that, please. And beyond that, I'm just trying to balance this new life of being a mom and doing all of this fun stuff with eye care. So before I get going and talking about the aging eye today, what I would like to clarify is what I like to call the 3 O's, because the different professions in eye care are extremely confusing and they all sound very similar. And when I meet patients for the first time, they try to tell me about their past care, and a lot of it is, I talked to so-and-so and they are they don't feel confident in what they're saying, which is totally fair. But let me highlight the difference between what I am and what some of the other professions in eye care are. An ophthalmologist is a medical doctor or a DO that are typically surgeons, and they are nowadays more and more specialized in a specific eye tissue. But there also are just general ophthalmologists as well. And that is a big part of eye care. A lot of you probably have an ophthalmologist that you know and love, and it is amazing. I love working with our ophthalmologists at Capitol Hill, and I hope they love working with me as well. Our opticians are the people who are kind of helping with the filling of the glasses portion. So you already have a glasses prescription, and then you're going to get lenses that are filled in that prescription. That's what an optician typically would help you with. There are a lot of other things that they can help you with under their licensure as well, but that's the main thing that you would know them for. They don't have to be licensed in Washington State, but a lot of them are. There are, the specific license is LEO for them. They can also do things with contact lenses. It depends on the state that you're in. And what I am is I'm an optometrist, and so it's basically kind of started as primary eye care, doing a lot of the glasses and contact lens stuff, and doing kind of comprehensive eye exams before you have some sort of specialized issue, essentially. And then it kind of branched off to being a little specialized as well, though that's not technically, recognized under our licensure. There is technically no actual specialties in my profession. But what we have kind of specialized in is contact lenses, and there's things like physical therapy for the eyes, which we call vision therapy. There's neurooptometry, helping people with different neurological disorders, pediatrics, as you can imagine, low vision, and clinical ocular disease. So that's just a little background on that. So what I really like to talk about when we're talking about the aging eye is the 5 top causes of vision loss worldwide. And I took this directly from the World Health Organization, and it is in the order which they have listed it as the causes of vision loss. So they are uncorrected refractive error, cataracts, diabetes, macular degeneration, and glaucoma. And when we look at these categories here, 2 of them are something that we can do something about, or really almost completely reverse. And then the other 3, early detection is really the key in making sure that this isn't something that gets worse faster than it has to, and that we can do something about it in the meantime. So the 2 that are reversible are the uncorrected refractive error and cataracts, and that's where we're going to start tonight. When we look at which kind of things in this category are affecting those as we age, pretty much all of these things are becoming more and more likely as we are aging. Though things like cataracts, glaucoma, and macular degeneration are taking up larger portions of the population that are affected by vision loss as time goes on. So you might be wondering, what's refractive error? Well, you know this one. You love this one. That's the one where you need glasses for it. So there's myopia, being nearsighted. There's hyperopia, which is being farsighted. Astigmatism, that's the tricky one to try to explain to people all the time. I explain it as being directional blur. And presbyopia. And if we think about which of these is most relevant to the aging eye, it is presbyopia. The other 3 are going to be related to the shape of the eye and the strength of the eye's focusing system and the length of it. And presbyopia is something that happens to us over time, and that is having difficulties with near vision, the stuff that you need reading glasses for. Or as I like to call it, your arm becomes too short. So really what it is that you have an inability to focus up close. And one of the things that I get asked all the time is, why is this happening to me? How can I stop it? Why isn't there anything better than reading glasses to help me with this? All very valid questions. The reason presbyopia happens and having these near vision issues is because of the way that the lens in the eye ages. When we are born, the lens in our eye is super, super thin. And what we need to do to see up close is we need that lens to flex to focus the light for us. And when we're born, that's super easy. And every year that we're alive, that lens grows like rings on a tree. and then it gets bigger and stiffer and harder for that lens to move. Even though the muscles stay extremely, extremely strong, it's actually amazing how strong they stay. So it gets hard to do that up close. And one thing that I like to kind of try to take the sting off of this process happening is, I don't know when the last time you talked to a toddler is, but have you ever noticed when a toddler wants to show you something, they put it right up to your face? That's because they have that really thin lens, and they have that instant ability to kick in that near vision focusing. And they don't know that you don't have that. And literally all of us have problems with doing that if we are not a toddler. So it's just varying degrees of how difficult it is for us. One thing that you may notice is that when this was first starting to happen, it was harder when things were really, really close to your face. We need more focusing the closer something is to your face. And that's why it feels like it's easier when you pull things farther away. So your arm literally gets too short for you. The process this starts to bother people, the age range is typically about early 40s, though it can depend on how farsighted you are and how much astigmatism you have and how nearsighted you are. So all three of those things really can play into how soon that bothers you. But then every time that you are noticing it in the beginning, it's going to get worse just about every 2 years. And then it feels like it's going to go on forever until it stops, typically about the early 60s or so. So the next thing that is a reversible cause of vision loss is cataracts. Look at that lovely thing. So if we think about how cataracts are affecting our vision, I have this lovely representation from the National Eye Institute. It is of two little boys, and we're trying to look at them, but things just seem a little cloudy here overall. Not something that would be super noticeable if you were living with this all the time, but the kind of gradual onset, it is something where you start to notice one day that things become very difficult. What I tell people about cataracts, it is very normal. We will all get cataracts. It's just a question of if we get there, basically. When I am also seeing people and they're in their 60s and they're nervous about getting cataracts for the first time, I tell them, congratulations, you lived a good life. Because the way that the cataracts form, they form from our exposure to UV light, to the sunlight. So if you didn't have any and you're in your mid-60s, you must not have gone outside very much. So I'm proud of you for being able to balance your life. If I do see somebody who's in their early 60s and they don't have much going on in their cataracts, I literally tell them, maybe we should think about going outside a little bit more. And that always makes people laugh. So we will see that kind of increase over time. Once it starts, it really does kind of kick up a little bit more exponentially in the growth of those cataracts. So 70% of people above 75 will have cataracts. There can be varying feelings of how this affects your vision. Overall blur is a pretty good one that people talk about. Glare would be another one that is a big thing that is affecting people's lives. And the most common complaint that I hear about cataracts is those headlights on the road are just getting so bright right now. And some of that is the cataract, and some of it is the horrible LED headlights that we're using now en masse, which are great for making things brighter for the driver, but terrible for everyone else. So it's a little bit of a, half dozen of, 6 of one and half dozen of the other. And a lot of times it will make you kind of block some of the light that's coming in, so you feel like you need a lot more light than you did previously. The things that will make cataracts grow faster than they would by themselves is, as we have already discussed, UV exposure. So my windsurfers, they always get cataracts sooner than everyone else. Smoking. There are a lot of different medications that can cause cataracts to form faster. Most notable in this category is oral steroids. And that is something that a lot of people are on for quite a while. So that can really make the cataracts grow much faster than they were previously. If you have a trauma or a surgery to your eyes, which I consider most surgeries trauma, That will definitely make cataracts grow faster. And then there are a variety of different genetic disorders where we have cataracts happening in very young people. So it can definitely happen in our younger population, is not only the older, but more common in the aging eye. I heard that you, as a group, have been exposed to eye surgery videos. I promise not to show you any of those tonight. Some of you will be happy, some of you will be disappointed. I'm sorry. But when I am in my process of trying to discuss cataract surgery, I don't perform any surgeries. So what I have to discuss with my patients is this something that we want you to pursue? And should I make a referral for you to do this? So I see people who are very apprehensive about it all the time. What I tell people is that there really isn't any other surgery where people are as happy afterwards and as happy the next day. So 95 to 99% of people have absolutely zero complications. Can you think of another surgery that is like that? Because I cannot. The things that we do have to be worried about are infection, inflammation, and retinal detachment. There are other things to worry about, but these are the big three that really we have to make sure that you know that these are possibilities during the surgery. What we do during the surgery is to minimize the risks of infection. There is an antibiotic that they have used that has dramatically decreased the amount of infections that have happened. So now we use that. It is a kind of trivial concern at this point. Inflammation is something that we do worry about, and there are drops that you take afterwards to try to minimize that chance. And then we monitor you for all three of those things, including the retinal detachment, which can be fixed sometimes if it is caught early. The other thing that's really nice about this surgery, it is topical anesthetic only, so you do not have to be put under for the surgery. But those who are nervous about it, I always tell them that don't worry, they're going to give you good drugs so that you aren't nervous because we don't want you kind of panicking on that operating table. So they're going to make sure they hook you up with something so that you're not nervous during the actual surgery itself. And the other amazing thing about it, it is extremely quick. I'm sure many of you have had cataract surgery, and it can be as little as 5 minutes per eye. So I tell people about 20 just so that their expectations are exceeded when they see their surgeon. It is awesome. One of the most common questions that I get from my patients is, hey, what about that refractive lens exchange, the RLE, that I hear on Jeopardy and on the radio all the time? And it makes me laugh, and my husband laugh when we're watching Jeopardy together, and that ad comes up. Well, really, what is refractive lens exchange? It's the same thing as cataract surgery without you having a cataract. So it's a clear lens exchange where there's just no yellowness to the lens inside the eye, but they're still doing the same thing, taking out that lens and replacing it with a clear piece of plastic. The claim on the ad is that you'll never need glasses again, and for some people that is absolutely true, but for anything that sounds like it might be too good to be true, there are things to consider, right? The technology that they use for the implant, so that you are having some sort of mix between near and distance vision, is they will try to basically have the same focusing capabilities as a bifocal or a progressive lens inside the implant of your eye. And it has these rings in it where the very center is focusing you for distance, and then the rings around will help you with the near vision. But it kind of has little jumps in the focus from far away to up close. So it can be tricky for people to feel like they're finding that sweet spot, and there will be spots missing. Some brains will have no problem with this. Some brains won't like it. I'm sure you've heard people that have tried to wear those progressive lens where it's got the reading at the bottom of their glasses, and that made them sick and they couldn't wear them. Same kind of thing with these implants, except for you can't just take the implants off. They're in your eye, so you have to get a whole nother surgery to get them removed. So it is certainly something to consider. Because it is something that would basically only help with your vision and not because you have a medical issue like a cataract, which really is a health issue because you are not safe to be walking around if you have something that can make you see better and get you to have more mobility. We don't perform the surgery RLE within Kaiser Permanente. We only do medically necessary surgeries. So we kind of consider it like LASIK, which is another refractive surgery of your cornea, and the other kind of refractive surgeries like PRK. So that is typically the end of it for me. I just say we don't perform it at Kaiser Permanente, and then my patients say, oh, not interested. This is where I live. One thing that is interesting about the cataracts that you may have seen in the last couple years, there was that study from UW that actually was using records from KP Washington and from the group health patients. It was about how cataracts may be tied to dementia, essentially. People who have worse cataracts and are living with them have been shown to also be developing dementia sooner and have worse dementia. And the other things that we have to consider when we're talking about this is, well, why are they walking around with something that we could just remove from their eyeballs? And that is what kind of made me personally a little bit skeptical about some of this information. Good to know for sure. It makes me want to send people off to get their cataracts out if they absolutely can, if they meet their qualifications. But it also makes me wonder, why are we in this situation to begin with? So some of the things that they did try to control for when they were doing this study to show that relationship was they looked at smoking, their race, their BMI, their general activity, and something called health patient bias, which at this time I don't actually remember what that is. I made the slides some time ago. But the thing that I kind of picked out when reading it, and so did the authors, it said that people with early cognitive problems may be less conscious of vision issues and thus may undergo cataract surgery at a later age. And that's kind of what my conclusion was before reading the paper when we're tying these two together. I had a lot of people that were very nervous about this when this first came out, thinking that if they had a little bit of cataracts, they would get dementia. And I do not think that is true at this time, but they are continuing the study. So we'll see kind of as our data gets pulled if that advice will change. The big question is, okay, so say I got a cataract. When's it time for me to get these bad boys out, right? Well, there's three main things that makes me consider a cataract surgery. One, it's reduced best corrected vision. So if you come up to my eye chart, if you're not able to see 20/40 or better, then we say, that's not so good. And the main reason for that is what the DOL would like you to see to be able to drive. So if you aren't driving, then that is a little bit more of a moot point than if somebody is a long haul driver. The second thing is basically if I look at your cataracts and I say, yep, those are moderate to severe cataracts. That's when they become medically necessary to come out. Typically that will go with the vision, so I can typically predict before I take a look at them whether or not we're going to be ready for it. And then the third and most important thing is if you feel like your activities are being limited by your vision, well, we want you to be safe, right? We want you to be able to do the things that you want to do in your life. No one wants to stop you from that. And that is often the deciding factor in the whole process there. So I often ask people, what do you feel like you've stopped doing over the last year or so? And everyone gets a little introspective about that. It's very interesting. Moving on to the next category of things that can cause vision loss that are associated with age, diabetic retinopathy. Diabetic retinopathy is, as it says in the name, related to diabetes. It is the leading cause of vision loss in the United States, but not the world. So when we're talking about this, I think it's helpful to be able to see what an eyeball looks like. So I have 3 pictures up here, and one of them is a disease-free retina. This is the one off to the left there. So it's got that nice orange tissue. It's got blood vessels. This yellow thing is the optic nerve. That's the cable cord that connects the brain to the eye. And this darker area in the middle is the macula, which we'll talk about later in macular degeneration. And that is where your brain is able to see 20/20 the best. The center image is a kind of moderate form of diabetic retinopathy. And what's different here, besides that it is a different eyeball, clearly, is that the changes to the back of the eye are caused by the lack of oxygen in diabetes. So we see that there are changes to this vascular system, and the eye is the only spot in your body that you're able to view blood vessels directly without having to cut you open. So it tells us a whole lot about the vascular system in general. It's very interesting that way. And some of the signs that it shows us is it will have bleeding, it will have blood vessels that are larger and puffier, and it will have other kind of deposits that will be released by the blood vessels in the eyes. Typically, this kind of diabetic retinopathy, it looks worse than it is. So we are most concerned about the third image up there. And this one is a retina that has quite a lot of white deposits, and it has quite a lot of bleeding in it. And when we reach this stage, this is the one that typically will cause pretty destructive vision loss. What does that mean functionally? I mean, it's nice to see a picture of an eyeball, right? But no one's as nerdy as me, thinking that's that cool. Functionally, what it's going to result in is basically having a whole bunch of different kinds of floaters, or it can cause retinal detachments. That third image I was showing you with the very sick bleeding eye, that happens because new blood vessels have formed in the back surface of the eye. And the retina doesn't like new blood vessels. It's a very delicate tissue, and blood vessels are very destructive. They kind of pull the house down with them. So what that does is it deposits bleeding in the center of our eye. That's called the vitreous. Our eye is full of a jelly-like substance, kind of interesting, that is between the lens, which is what we were talking about with the cataracts earlier, and the retina, which is what we're talking about now. And that area is supposed to be nice and clear. If it's not clear, then we see black spots or different colored spots in our vision. And that can be what we call floaters. Bleeding is one of the things that can be floaters, but there are more commonly other kinds too. If we think about what that's going to do functionally for someone's vision, if you've got a bunch of blood in front of your film to the camera, essentially, it's going to be pretty hard to see out of that. And if you have a retinal detachment, it can make it feel like there is a part of your vision that's just kind of pulled away. So kind of like a veil or a curtain. So after looking at that sounds pretty scary. How can we avoid this happening to us? Well, a lot of it is just, the same stuff that everybody tells you, is that try to keep yourself as healthy as you possibly can. So on the eye part, I always recommend regular dilated eye exams. Dilation, I know, not the most fun thing. It's where we put those drops in your eyes and it makes things kind of blurry. That helps me to see inside the eye. And the people who don't want their eyes dilated the most are often the people that should have their eyes dilated the most. So if you're doing that, then you're doing a whole lot. Keep using your medications as directed, especially if you currently have diabetes or are pre-diabetic. That is helping us keep our blood sugars under control or everything else under control so that this does not bother us. We watch our A1C, which is one of the blood glucose markers. It basically is kind of like an average over time, over about 90 days, which is how long blood vessels will live for, or blood cells. Diet can be important. So studies have shown that when we have diets high in omega-3 fatty acids, fresh fruits, and vegetables, then we are less likely to have vision loss from diabetes. regular exercise, control over the blood pressure and cholesterol, and avoiding smoking and alcohol consumption. So yes, pretty much the stuff that everyone says. One of the very hot topics nowadays, as things have been changing with our technology, is one of the next categories that can cause vision loss with aging. This one really is truly most associated with age, and that is macular degeneration. So if we look at an eyeball again, I have a nice healthy eye model off to the left, and we're looking at it through the side like we cut you open. And on the other one, we have macular degeneration, and this is trying to show you where in the eye the macula is located and why it would matter that it's in the center, essentially. So when we think about how light would be focusing inside the eye, it kind of follows that little canal that is in the picture over here. If you can see it, there is basically a line that is going through the retina, and it's leading to a spot in the back. The light will focus from the lens to this spot specifically, and that is why your brain focuses all of its good developmental skills on this spot specifically to try to see the best. The rest of your retina can see. That's why we have peripheral vision, but it does not see nearly as well. It sees about a tenth as well. And we're looking at an eye chart compared to the very center of best vision. So we put a lot of stock in this very spot, and this is the spot where macular degeneration will happen. So who's going to get macular degeneration? Well, it's a bit tricky. So here's what we know right now. It's more common in those who are older than 60, those who have a family history, those who spend a lot of time in the sun, those who are obese, those who are smoking or have smoked in the past, those who eat a diet that is high in fat and or low in nutrients and antioxidants, those who have high blood pressure, those that are inactive. And then there are two additional risk factors that is debated right now. One of the risk factors is having light-colored eyes, and the other is being Caucasian, essentially. And with these ones, now we're not sure if this is because this is the population that we have studied and has had access to care to be able to know that they have macular degeneration, or if it's truly an association. One of the things that we learn is kind of classic about macular degeneration is basically being a Scandinavian woman who is over 60. That is the person who you expect to come have macular degeneration. But I'm not as convinced as I was when I first learned that is the case. And I'm interested to see how things change now that we have a little bit of different ways that we're monitoring some of our healthcare data. So really, when we're having macular degeneration, it can be pretty tricky overall because you have very little control over it. It just kind of happens to you, right? With diabetes, at least, we had something to try to focus on. We try to take pieces and fight it that way. With macular degeneration, a lot of it is that it's just happening to you. Well, we do have tools to fight macular degeneration, but it is easier or more possible when we have wet macular degeneration. I shouldn't say easier. So what is the difference? You probably hear this when you're talking about it too. I have dry AMD, I have wet AMD, and you probably will know that wet seems to be worse when you talk to people who have it. Well, dry macular degeneration really means that you have changes to the retina that have caused it to be difficult to have the back of the eye do its job in recycling the information that it's getting, essentially. And there's various levels. You can have just changes and doesn't mean anything for your vision. And you can have horrible dry macular degeneration that takes almost all of your vision. And what we worry about when we're having dry macular degeneration is that it will change into wet macular degeneration. And that is where we're creating new blood vessels in the back surface of the eye. Just how we were talking about that for the diabetes, how that's destructive, how that takes the retina with it. It will do that as well, except for it does it primarily in that spot that helps us to see the best. So it can be often a lot more dramatic when we're experiencing it from day to day. Functionally, what that means is that when we are trying to look at a child's face, somebody who has normal vision just sees that child. Somebody who has kind of moderate dry macular degeneration typically will see them a little bit distorted, maybe a little bit darker. They probably won't know it's darker. Then if we have things progress, it will get more and more distorted. And with things like advanced dry macular degeneration, or really most stages of wet macular degeneration, it can take entire sections of the center of the vision away. And on the picture, it looks black. For most people who are describing it, they just describe it as being gone, though people can describe it as being white, black, gray, any color in between. But most importantly, when they try to look at something, it basically disappears on them. It can make it really difficult to recognize faces. So if your friends cannot tell who you are, please forgive them. Really, the top thing that I hear people complain about is difficulty with reading, because that reading is one of our highest acuity activities. Acuity meaning that it needs the best vision, and it is something that is very obvious when you're missing even some letters on a word. Nevertheless, if you're missing entire words, or if you are missing where the next line is, all of that can be very, very tricky in macular degeneration. It also is, because of the mechanism of macular degeneration, it's not able to kind of recycle things, so light feels like it sticks around longer. So after images, when you stare at something really bright and it sticks around for a while as you walk away, those stay around a lot longer. People are a lot more sensitive to light and to glare, and they will just have a lot more difficulty in the darkness as well. So what can we do about it? Well, we kind of talked about how this isn't the most easy thing to fight. There are a few things that we can do. Well, the same studies that we're talking about, kind of who is more likely to have macular degeneration, notice that smoking tends to be associated with having macular degeneration. So that's what we call our only modifiable risk factor in having macular degeneration. We do recommend having UV protection. Less light means less to recycle, means less damage happening overall. A diet high in omega-3 fatty acids and leafy greens seems to be something that slows down the progression of macular degeneration. And we find that those who have good control over their blood sugar, their blood pressure, and their cholesterol are often having less severe disease. That does not mean if you have severe disease that you have done these things wrong. It just means that the population data says that this is something that we can sort of tell you might help a little bit. And well, what kind of treatments do we have? Well, I've told you there's not really treatments for dry macular degeneration. That isn't entirely true anymore. There was a drug that was approved this year that has been shown to reverse some damage only in cases of what we call geographic atrophy, which is really advanced damage to the retina. We will see kind of how that goes. I'm still reading about the mechanisms. I don't think anybody understands it. I can't really believe it's happening, but hey, if it works, it works. I'm happy. And if we have moderate macular degeneration, there is a formulation of vitamins, specifically AREDS2, that has been shown to reduce the progression of moderate macular degeneration into severe macular degeneration and to wet. And the brand name of that is Preservision, which is from the pharma company Bausch & Lomb, but they have the same formulation from a whole lot of companies, and honestly, often that's a lot less expensive than AREDS. So whatever you got on that formulation, awesome. People ask me all the time, should I take AREDS as a preventative vitamin? I'm of the opinion that if you do not have macular degeneration, it is not necessary. It is very high antioxidants. That's what's in the formulation. And that can be really hard for our liver and our kidneys if we do not need them. So too much of a good thing can be too much. Is it worth worrying about most of the time? Not really. For most people, it will be fine if you want to take AREDS, but it is very expensive. So I just want to make sure that you're putting your dollars where it matters to you. And if that's where it matters to you, I support you. For wet macular degeneration, we do have a variety of treatments for it. The older style treatment are laser procedures to try to lessen the amount of work that your retina is doing. And now the most common thing is to get injections in the eye. This stops the growth of new blood vessels. And I'm sure you know people who are going just about every 4 weeks to their eye doctor to get them done to try to lessen their progression. And people get really close with their retinal specialists when this happens to them. So I'm seeing some nods of understanding, and maybe these things are happening to some of us in this crowd. The next cause of vision loss is glaucoma, and this one is the most common reason to have vision loss in the world. And glaucoma it's a tricky one because it doesn't feel like much, it doesn't seem like much, and it's hard to explain. So how kind of I explain it is a vision loss from the outside in, so slowly that your brain doesn't typically know that it's happening. There are other kinds, but that is the most common kind. So it technically is a disease of the optic nerve, and that is the cable cord that connects your brain to your eyes. You have heard that pressure is related to glaucoma, and that is true. The pressure in the front of the eye can press on the rest of the eyeball and put damage on that tissue. The nerve is located in that was that yellow thing that I showed you in the retina, and it is located near the macula, so it's near that area where the light focuses. It's very tricky, as I said, because it can not feel like much. The spot where it happens, the optic nerve and the retina, they don't have any pain sensors, so if something's happening, it can't tell you that something is wrong with our age-old way to know things are wrong with pain. So it's just vision loss. And the way that the optic nerve is collecting information, it is essentially a funnel of all of the light-sensing cells in the eye that goes back into the brain. And it's kind of like having a problem with a kink in the hose. So information isn't flowing out through that funnel. That's why we get loss of vision from the outside in, because it's the outside areas that are coming into this funnel, if that makes sense. So who gets glaucoma? Well, glaucoma, I tell people, is like a puzzle. So there are many pieces to this puzzle, and we're trying to look at how your individual risk factors play out to see if we should be doing some treatment for this. So age is one of the risk factors. That's why it's on our list to talk about today. 90% of the people who have glaucoma are over 55. That is crazy. Elevated eye pressure, while being something that we talk about a lot, because it's the way that we can control the progression of glaucoma, is only one part of this equation. So it is a risk factor. You can have fairly high eye pressure, and that can be fine for you. Probably not, but it can be. Having trauma to the eye, or history of trauma, or as I said, I consider surgeries to the eye to be trauma as well. That can make it more likely for you to have glaucoma. Your ethnicity seems to matter in the progression as well, and the risk factors. We do find that African Americans are 6 times more likely to have vision loss from glaucoma. Family history, that can be important, but only first-degree relatives. So I am not particularly worried if your great aunt had it, though I am sad for her. And vascular risk factors, which seems to be kind of the moral of every story here, right? High blood pressure and diabetes, that can make it more likely for us to have damage from glaucoma and makes us want to treat things faster. So how do we find out that things are getting worse if it doesn't feel like anything? Well, we look at that nerve in the back of the eye, we compare it over time, and we see how things are going. That's difficult to do when we compare to each other, so we have fancy scans to be able to detect it, and we have gotten a lot better at that, so we're catching it much earlier and much more accurately than we were before. And then, I don't know if any of you have done this, if you've done a visual field exam. If you have, you know it's not the most fun thing in the world. And that is where we have you show us, are you missing anything in your peripheral vision? So we make you play a little video game, to show us what you can see and cannot see out of each eye. And we track that as over time as well to see if there's any damage that you don't know is happening. How do we treat it? Well, it's easier earlier on, like with most things, because our vision loss is irreversible. We can't give you any retina back after it's been taken away from you. So we are very, very gun shy about kind of treating people with this. We want to do it as fast as possible. We will lower eye pressure, and that's kind of the moral of the story. Eye drops, very common way. There are lots of surgeries that can do it, and there are a variety of laser procedures as well. We typically start with the eye drops, though. And something that I was including in my kind of 5 reasons that we'd have vision loss with age. This wasn't related to that, but I do, since I am interested in low vision, have quite a lot of people who are at risk for falling. And the role of vision in falling is a big deal to me. So when we look at kind of who is more likely to fall, I think it would be obvious to a lot of us that you're more likely to fall if you can't see, right? So does the data support that? Well, yes, it does. There is a study that says that people who are seeing worse than 20/60 out of both eyes are more than twice as likely to have a hip fracture. That is a lot of a difference there. Things that we would also care about is that poor contrast sensitivity, and I'll talk about that later, and depth perception are also associated with fractures. And having the poor visual acuity or a part of your vision being missing, your peripheral vision, like we were talking about in that visual field test, that can also lead to a risk of falls and hip fractures. But the big thing that really stood out to me when making this presentation was that there is every 20 minutes, an older adult dies from a fall. That is a very scary statistic. I had quite a lot of people that were asking me about how their vision was being affected by their masks fogging up. And that is something that we've had to deal with this last 3 years that we never would have thought about before that. And what we have been seeing with that is that there are different strategies to keep the mask from keeping you falling. And they found that if you're trying to look down while you're wearing your mask, typically your mask will push your glasses up a little bit, and it makes it more likely for you to fall. So they do not want you to look down to the ground when you're walking around. They want you to keep looking straight ahead and just slow down a little bit if you're feeling uncertain. So how can we use things in the environment to keep us from falling? Well, the thing that I was talking about earlier, contrast, so important for pretty much everything with vision. Regardless of whether you have good vision or not, if you've got better contrast, everything is easier to see. So contrast is the ability to distinguish an object from its background. I also describe it as the ability to see different shades of gray. So in particular, out in the real world environment, things that are very tricky, you probably have noticed this when out and about, you feel uncertain on stairs that are concrete, that are just gray on gray. There's nothing that shows you the edge of the step, and it can make it really tricky to know where to put your foot. So something else that you've probably noticed about places that you like to go, and I'm sure in this building, there is edges to the stairs so that you have better contrast on where that edge is. So out inside where it's going to be on gray concrete, the stripes will often be yellow or white, and that is very easy to see against the gray or dark background. The inability to see contrast can more than double your risk of a fall. So it really is a big deal that we have this set up correctly in the environment. When we're thinking about other situations where contrast can be helpful for us that aren't related to falling, then really everything. It's going to be easier when you have better contrast. When you're looking at this plate of pasta, there is a plate of pasta that is on a white plate, makes it pretty hard to see where the pasta begins and ends. This other plate is red. It has better contrast with the kind of beige pasta, and it's a lot easier for you to see exactly how much pasta is on that plate. So things like this are always my kind of list of things to consider to make your life better if you have reduced vision. I'm often recommending people get different types of cutting boards, like one white and one black, and switch them out for different types of objects that people are cutting. And even if we can't make modifications like that, if we can make the lighting better in the room, unlike this room, which has very dim lighting, then it will make it easier for us to see contrast. In particular, when you think about things that have really bad contrast out in the world that wouldn't be related to falling, the newspaper. I hate the newspaper. I like that it's a fun thing to read. I like the news, but I hate newspapers themselves because they are gray, and then they have darker gray text. Is there anything else that we try to read that has that bad contrast? There's not. This is where people have a lot of issues. So while we can't do anything to make the newspaper print any bigger, while we can't make it any easier to see the background or the text itself, what we can do is we can turn up the lights all the way, and that way we can see that the text is there rather than it being kind of a gray-ish blur overall. So that is my big recommendation for newspaper readers. Please use as good lighting as you possibly can. And if you can figure out how to use a digital version of your newspaper, that often has much better contrast. When we are talking about different things that we can do in our life to improve our vision after we have had vision loss, a lot of it that I deal with is trying to recommend visual aids. So a lot of it is things like contrast, and honestly, there's a lot we can do with contrast to make everyone's life better, but that doesn't always do everything. So trying to have our environment be as clutter-free, so that way it's easier to find the things that we're looking for, and so that we don't trip over items. Easier said than done. Beware of low contrast rugs. I've had quite a few patients that have tripped in their houses and had hip fractures because they have a kind of beige rug on their normal beige carpet and can't see it. So there we go. Having something darker there would have made all the difference. Adjustable lighting can be a big deal. I love what we call gooseneck lamps. I do have a picture of one of my favorite kind of adjustable lamps. There's a man sitting there. I apologize, it is a little small. But having the ability to take a light and focus it between yourself and the object that you're looking at will give you maximum lighting without maximizing the glare, because the glare can really be a big deal. It's often really tempting to have a lot of really beautiful patterns in your beddings and your rugs and your couches, things like that. But when we have vision loss, it can make it a lot more difficult to find things that you've set down on those items. So avoiding kind of low contrast patterns and muddled colors can really make a big difference in your ability to find things. Magnifiers can be very helpful. It's a tricky world out there though, so that's one of the things that I make a lot of recommendations on, and it really depends on what you're doing and what you find helpful and what you don't find annoying. And that second one is the harder sell most of the time. Tinted lenses can be very helpful. They can help enhance contrast. I really do like yellow tinted lenses for a lot of things. It can minimize glare and enhance contrast for a lot of people. If we're not liking the yellow, a lot of people also like brown. If we're wearing sunglasses outside around here, brown is my preferred because it enhances contrast. If we were living down in California, everyone likes to wear the gray lenses because it's very bright and you just want to cut down the total amount of light. You don't really need to enhance contrast. We need that here because we've got the clouds. It makes a big difference in the situation. You may have found that you gravitate towards the brown lenses. And telescopes and binoculars can be very helpful, but it's more helpful in situations where we've got peripheral vision loss, like in glaucoma. And that could be very tricky to learn how to do. And I'm realizing that I'm taking a lot of time, so I'm going to speed up a little bit here. And here's my overall kind of tips for the aging eye. So get a comprehensive, regular, and dilated, please, eye exam. It's very important. Focus on the modifiable stuff, the stuff that you can control. So, as we saw in most of those, diet, exercise, and protection from sunlight. Try to control your vascular risk factors like blood sugar, blood pressure, and cholesterol, which kind of goes in the first thing as well there. Keep your eyes well lubricated. Wear appropriate eye protection for your activities, please. Cannot tell you how many pieces of metal I have removed from people's eyeballs. And sudden changes or loss of vision or sudden eye pain are all things that I want you to get seen immediately, and preferably by somebody who has a specialty in eyes. Getting stuck in urgent care with really severe eye pain can really suck. And I don't know how much time we have, but I have time for questions now. Perfect. And we've got people with microphones, and they'll be coming around when you have questions. Please raise your hand.
Is lutein good for eye care?
Perfect. Good question. The question about lutein. So lutein is one of the ingredients that is in the AREDS 2 formula. So yes, it is an antioxidant that can be helpful. It is what we find in leafy greens, and that's why we have that recommendations that leafy greens is good. I would rather you get it through diet if possible than by supplements, because by itself, without the rest of the formulation from AREDS, there's no clear tie that you're absorbing enough to be helpful. But there is a lot of the other antioxidants that is also existing in a leafy green. So that's really what they're trying to deliver quickly to you in the PreserVision formulation.
Would you continue using lutein?
It depends on how you are feeling about it. If it's difficult to take at all, I would say no, don't take it. If you can just keep eating a salad, for lunch every day, I think you're better off using that money for something else, honestly. I am also very budget conscious, and that is probably the product of where I am practicing right now. If that's not a concern to you, if you have a lot of money to throw around, then might as well keep taking it. Completely up to you and your budget.
Thank you.
Is there any work over here? Is there any work being done that you know of on regenerating the optic nerve?
Oh, absolutely. They're doing their darndest, aren't they? Really, what the first step is going to be trying to see if we can get any real life going back into the cell that is in the optic nerve. It's called a ganglion cell. There were quite a few of my professors at UC Berkeley that were working on trying to see if they could even just, I guess I wouldn't say revive, but revitalize cells that had been damaged that aren't quite dead. And yes, the ultimate goal would be to get retinal cells and retinal ganglion cells to be able to kind of repair themselves. If we could do that, though, we would also be able to have a variety of cures for a lot of neurological conditions. So I can't think of anything that is a large kind of human study, but there's a lot of primary research that is going into that directly, yes. If they can figure it out, then we'd all be happy campers. If you are somebody who has any of these conditions and is worried about kind of what our current options are, I used to have a slide in here, and I would put it back in for the one that we have, that was different ongoing clinical trials that are going for these different conditions. And for anything that you might be interested in, if you go to, if you just search clinical trials, whatever condition, it'll point you towards what's available right now. There's not a lot going on in our area. There's a couple for macular degeneration that are in Washington, and I haven't checked on the others in a while. But we had quite a few going on at OHSU as well.
Can I hear your thoughts on double vision?
Oh, I have many thoughts on double vision. So there's a lot of causes to double vision, and they can be a tricky thing to try to suss out. A lot of them are neurological conditions that we want to rule out, but once we've ruled out that there's something where you're not having a stroke, essentially, or having a brain tumor, which can cause double vision, then beyond that, we just are trying to manage the cause of it typically. I do work with quite a lot of people who are existing with double vision from different conditions, and we can move the light around, try to eliminate it. We can get different solutions on that as well, but it's an awful thing to deal with, and there's a lot more than there used to be. So the old advice used to be that you have double vision, well, close an eye. Now you don't. So I would hope that we would try other options before anybody needs to walk around with an eye patch permanently. But I am happy to expand, but that is a whole category of study there. That is a tricky thing to have more than broad thoughts on.
How important is it to track what's happening with macular degeneration? Our insurance company has an opinion that it's, once or twice a year is more than ample. My ophthalmologist has a very different opinion.
I think it depends on where we are and what we're worried about, what other conditions we're managing in the meantime. So yes, I also have this issue with insurance quite a bit. I do like my primary insurance with his Kaiser Permanente, but we do have competing interests sometimes. So it really depends on where we are. So the advice on following these conditions depends on the grading of them. So for most people who have macular degeneration, about more than 50% being seen once a year is the standard of care, because there isn't anything that we can do for moderate or even early macular degeneration besides make sure it doesn't turn into something worse. For a lot of it, the advice is, well, if we're checking every year and you're not noticing a change in symptoms, then probably something didn't happen. But monitoring those change in symptoms can be a big deal. So if we're noticing really any changes, that makes it medically necessary to go back and get a check. So that can be the gap that is bridged between what the insurance thinks and what your ophthalmologist thinks.
Can you speak briefly about dry eyes that drip constantly?
Yes, I knew we would probably be talking about dry eyes a little bit, because that is something that a lot of people deal with. Dry eyes it's an awful thing to deal with, because it really just requires you to try to lubricate your eyes quite a bit. There are a lot of different other types of dry eyes, things that can be related to different systemic diseases like Sjogren's disease, where we don't have the ability to create tears, essentially. And a lot of other autoimmune diseases can make it very tricky for your system to maintain and create your tears. But most of the time, people are having an issue with their tears evaporating on them. So using things like warm compresses to the eye can be very helpful. That helps with the oil glands within the eyes, which when we blink, they're supposed to release an oil that coats the surface of the tears and keeps them from evaporating. So having people do warm compresses to their eyes nightly for about 5 to 10 minutes can be very helpful for the majority of people. However, just like we have dry skin, we're going to have dry eyes, and that's going to change with the weather too, right? Right now, pretty bad time for dry eyes because it's very not humid inside in general. And we need to replace our tears so that way we're not having that burning, stinging, and watering. Watering is typically because of dryness. Just like our skin will get oily when it is dry, our eyes will water when we're having dryness. We're basically just designed to flush things out that are getting in our eyes, and that's all your eye knows what to do. It says, I'm hurt, let's water. So my advice typically is when we're having these situations is to use artificial tears. I really like, for my first step, to use a tear called Refresh. That's a green bottle. I like that one because it's pretty cost effective, and it is something that is a multi-use bottle. I like the preservative in it. I think it does a good job. If we are needing to use them more than 4 times per day, then that preservative in the bottle is more harmful than helpful. And we need to step up to something that does not have any preservatives to give us any irritation. And they have individual little tier packages that don't have any preservatives. One thing that I was hoping to find time to talk about that I did not. Did you guys hear about the eye drops that were killing people? Is that something that we're worried about at all? I have a lot of people who are. So how did this happen? Well, it was in mostly non-preserved artificial tears. So the ones that I recommend are the ones that come in the little individual packages. The ones that killed people it was a multi-dose. So we have big bottles that are supposed to have a one-way valve essentially, so that way we can't have any bacteria enter into the bottle. Something happened. We're not sure if it was with the bottle design or if it was with the manufacturing process, and 81 people got a strain of bacteria that is very difficult to battle with antibiotics, and 4 people died from it. However, as scary as that is, it was only this type of artificial tear from the Delsem Pharma company and their Ezra Care products. So they voluntarily recalled things. I believe it was in January of this year. And after they did a voluntary recall, there was a couple facilities that were using them as their administered artificial tears. And so most of the deaths actually occurred after the voluntary recall, which I thought was kind of not what you would expect. So I wouldn't worry too much about something like this happening if we're getting it from one of the big pharma companies, right? Because Bausch & Lomb and Johnson & Johnson, they can be expected to pay out if something happens to you. Ezra Care and Delsem Pharma, I don't think anything happened to them. I think they just folded and went, whoops. So I would want to trust in the medical legal powers of Johnson & Johnson over somebody I've never heard. So I'm wanting people to use the Refresh or Sustain for their multi-use bottles right now, avoiding the non-preserved multi-use bottles just for right now. And once things calm down, we can consider the non-preserved in a big bottle. Now that they have had this happen, the FDA is going to have a much higher clearance to get those types of bottles approved. And so we talked about tears, and you probably will find that the wateriness is the worst when walking outside, specifically in the wind and cold. So basically in the morning right now. So taking the tears and putting them in your eyes after you're back from your walk is going to make you not be watering when you're talking with your friends over breakfast. Yeah. We wait for the microphone for our friends who need it.
On? Yes.
Yes.
Right. Yeah, I'm being treated for macular degeneration with an injection in both eyes and so forth, and it's fairly often. The interesting thing about it is that I see very well. I mean, that is, I don't even remember how I discovered this problem, except with the grid, you know, that little grid that you can, and the lines were wavy and that said that something about it. I think when I saw that, I talked with the ophthalmologist about it, and that's how I discovered it. But it was kind of striking that it had no symptom. You know, it could have gotten a lot worse, and I never would have known it.
Absolutely. It could really sneak up on you, can't it?
Yeah, right. Yeah, I'm also not sure who's paying for this. I mean, it's enormously expensive, and I guess my insurance is picking it up somewhat. I'm not sure.
Yeah, it is expensive. They do have a variety of different options too, and the least expensive one is often the one that requires the most dosing. So you have to go in, every 4 to 6 weeks for that one. But that is typically how they try to get around it.
I think maybe that's it, because I signed something in the doctor's office and paid $35 or something like that, which got me into something, but I never knew what it was.
Yes, yeah. Typically, that is authorizing that they can do the injection and that they could bill your insurance for it.
Okay, right, yeah, I thought so. Thanks.
That's why the comprehensive dilated eye exams are important.
This is really maybe a side issue, but do you have a suggestion when we have to make a change of our optician, how you go about finding one? I mean, there are all these names out there.
Of trying to find anybody in general, of any of the three O's, or any doctor of any kind.
Somebody I really want.
Yeah. Well, it can be really tricky, yes. So first and foremost, I think something that people don't put enough emphasis on is that they've obviously got to be somebody who works with your insurance, which for a lot of us here, it's not going to be as difficult as it is for some of the people outside of this room. So that's step one, somebody that's going to have this paid for so you don't have to pay $400 out of pocket, which is what it costs to see me. Can you believe that? I can't believe that. It's Kaiser Permanente who says that, not me. But the next thing that I would look for is, honestly, I would look for somebody who is known to kind of specialize in something. It doesn't necessarily have to be anything that's crazy. Looking for somebody who has extra training would tell you that they're trying to keep up on things in general. Optometrist, which is what I am, we don't need to have a residency training. It's not required. We can practice immediately afterwards. So if somebody has a residency, especially in Washington State where we don't, the only residency for optometry in Washington State until 2 years ago was at Kaiser Permanente. So there's a very small amount of us who got trained here. That would be a big deal for me. The reviews are going to be a lot of it, and trying to make sure that the people who are seeing this person do not feel like they're being sold to. Trying to see that they focus primarily on the medicine first and the making money off of glasses later. Well, that is important so you can stay in business. That is something that I was not interested in, why I work at Kaiser Permanente, because then I don't have to sell things. Does that answer your question? It's a big job. It's a lot, and you have to do it for every person ever. It's the worst. It's like you don't have eyes or teeth. Why isn't it never included in the regular insurance package? They didn't ask me, clearly.
My vision, they say, after my cataract removal has been 20/20 for a few years.
Woohoo.
But now I notice sometimes if I don't wear sunglasses outside because I'm light sensitive, I'll walk into the lobby and for a moment I'll see kind of a green fog. Is that unusual?
No, that is not unusual. You are getting so much more light now compared to your natural lens. Even before, when it was clear, it was thicker, so you were just getting less light coming in through in general, and your retina is just getting the full force of it. So it just takes your retina a second to say, okay, I've received this information. Now I've got to clear that away, like an Etch-a-Sketch, essentially, and then get it to come back. So it can be something that feels like it gets worse over time because we feel confident in changing our activities too. We get to do more stuff and we believe we really can do it as the years go on. It's crazy how much it changes your life. I think we've got somebody over there.
I was just going to mention that I saw my ophthalmologist on Tuesday.
Woohoo!
And I wanted to be sure I understood what kind of a risk I had for macular degeneration, because people in my family have had it. And usually I don't ask the right question, but I asked the right question this time. And I asked her, will I be reading okay in 3 years? And she said, of course. So that's for those people who have any concerns about macular degeneration, that might be the sort of question you'd want to consider asking.
Good one. Yeah, I don't typically worry about people who have a family history that don't currently have any damage at all. The 3 years time frame is a pretty confident one that I could say that things aren't going to change drastically by then. Wet macular degeneration can be that fast, but not typically. All right. Well, it looks like this is the first night of my baby's life that I didn't put him to bed.
Well, we thank you so much for making time to come to be with us. Don't you all agree it was useful to have this? And thank you all for coming to the program. We were joking about would we see people here tonight or not. And it's nice to know, but we do care. I think if you had asked, I think it might be interesting when you do this talk, if you say how many people here have had cataract surgery and how many, because many of us have these conditions or we're concerned for our families of generating them. So it's information we can give our kids and grandkids about getting healthy and for ourselves too. I hope it's helped you tonight. Thank you.